Transvaginal ethanol sclerotherapy for endometrioma in 10 steps. Endometriomas occur in 17 to 44% of young women with endometriosis who generally complain about pelvic pain or infertility. In this situation, the surgeon has to face two challenges: preserving the fertility while improving the quality of life. The aim of this video is to promote this technique through 10 steps in order to make it more accessible for patients. Step 1. Planning of the surgery. Ethanol sclerotherapy was indicated because this patient presented with an endometrioma, pain, and infertility. The diameter of the endometrioma has to be between 25 and 100 millimeters. All patients had an extensive MRI mapping of the endometriosis by expert radiologists to confirm the endometriosis origin of the cyst and to create the suspicion of malignancy. As sclerotherapy is not the standard treatment, indications were discussed during multidisciplinary endometriosis meeting and appropriate information was given to all patients. The objective of the sclerotherapy was to avoid laparoscopic cystectomy and decrease the risk of ovarian reserve injury. All women had a vaginal swab to detect preoperative vaginal infection 1 week before the procedure. If it was positive, the infection was treated and the procedure was delayed. The intervention was performed in an outpatient department in gynecological position by a trained gynecologist under general anesthesia and under transvaginal ultrasound guidance. General anesthesia is not compulsory, but we prefer it because it ensures that the patient does not move during the procedure. We choose to administer cefazolin 2 grams antibiotic prophylaxis to prevent post-sclerotherapy infections despite the limited evidence to support it. Indeed, post-procedure infections may be underestimated in the literature. Step 2. Materials. A strict sterile technique is used. We need an ultrasound unit with a transvaginal probe, a sterile cover, and gel for the probe. We use a needle guide, like for oocyte retrieval, a single lumen puncture needle, saline solution, several syringes, and 96% pure ethanol. We use a 17-gauge needle, but a 16-gauge can also be used to facilitate irrigation. A 3-way stopcock or double lumen needle may as well be used to facilitate suctioning and irrigating with different fluids without having to physically remove the syringe. An assistant is useful to avoid unwanted movement when the cyst has been punctured. Step 3. Ultrasound examination. First, the position and size of the endometrioma are recorded. The patient's bladder has to be empty. It's necessary to apply strong pressure with the probe in order to make sure to be as close to the ovary as possible and therefore to keep the neighboring organs as far away as possible. Step 4. Transvaginal puncture of the cyst. The puncture of the cyst is performed under ultrasound guidance using a single lumen needle. The ultrasound will document that the needle can safely reach the endometrioma. Once the needle is in position in the cyst, it is important not to move until the very end of the procedure. This is where the role of the assistant comes into its own. We advise the operator to prepare a seat before the puncture to ensure the most comfortable position and reduce involuntary movements. Step 5. Aspiration of the cyst. The cyst content is totally aspirated and its volume is measured in milliliters. We use a small volume syringe to make the aspiration easier, for example, a 10 milliliter syringe. This is especially useful when the endometrioma's fluid is thick. According to our experience, this technique is most effective for cysts between 30 and 70 millimeters. It is possible to perform sclerotherapy on cysts measuring up to 100 millimeters, but patients are informed of the risk of failure, especially when the endometrioma is a long-standing one. In this case, it can contain solid clotted parts, which cannot be aspirated. In case of failure, a laparoscopic cystectomy may be offered. If the patient has been informed accordingly and is willing to, the laparoscopy can be done during the same time. Step 6. Cytologia of the cyst. A sample of the liquid is systematically sent to cytology. This confirms the nature of the cyst and minimizes possible malignant etiologies. Step 7. Flushing the cyst with saline solution. The cyst is flushed with saline solution until obtaining a clear liquid. This is generally achieved after 2 or 3 times. The installation has to be smooth and continuous. If necessary, reflush the needle to clear it if it is clogged and break up loculations. Step 8. Injection of 96% ethanol. The ethanol is then slowly injected at 60% of the initial volume of the endometrioma. The cyst should not be overextended to avoid its rupture and ethanol diffusion into the pelvis. The maximum volume of ethanol for intracystic injection is 60 milliliters. Step 9. 10 minutes exposure to ethanol. The ethanol is left in the cyst for 10 minutes as suggested by the literature. During this step, it is important not to move. A timer is useful to make sure that the 10 minutes are completed. Step 10. Aspiration of ethanol. The ethanol is totally reaspirated. The recovered volume has to be noted. If some ethanol is missing, we recommend that the patient blood alcohol level be monitored and that the anesthetic team be notified. If the blood alcohol level is positive, the patient is more closely monitored. The blood alcohol level usually becomes negative within a few hours. The procedure is considered successful if the remaining endometrioma is measuring less than 20 millimeters, as described by Yazbek. Ethanol sclerotherapy for endometrioma is a rapid outpatient procedure requiring little equipment for a low cost. This technique can be offered as an alternative to cystectomy. We presented 10 steps to make the procedure easier to adopt and to reduce the learning curve.